Welcome to the Deep Dive. This is where we help you get your head around complex topics, specifically the material you flagged for us.
Exactly. And today we're diving into your MSRA revision notes on gynecomastia.
Right.
Our goal really is to pull out all the key high-yield info from those notes and make it memorable for your revision. Think of it as your tailored audio guide.
Absolutely. Medical notes can be, well, dense, can't they? So we're aiming to make this digestible, maybe even a bit less daunting. We'll cover the definition, causes, the whole works.
We'll try to drop in some memory aids along the way. Your notes are pretty comprehensive definition, etiology, risk factors. It's all in there.
Okay, let's jump in then. First things first. What exactly is gynecomastia? Lay it out for us.
Okay, so simply put, gynecomastia is a benign that's non-cancerous enlargement of the actual breast tissue in males.
Right.
It starts to look a bit like female breasts. For exam purposes, the specific definition you need is more than 2 centimeters of palpable, firm, sort of glandular tissue right under the areola. That's the glands and ducts growing.
So just to be clear, this isn't about someone carrying a bit of extra weight on their chest.
Precisely. That's a really key point.
Yeah.
We're not talking about pseudogynecomastia, pseudo meaning false, which is just excess fat deposition. This is actual glandular tissue growth.
Right.
And it's driven by hormones, fundamentally. An imbalance between estrogen and androgens causes this growth. It can be on one side, unilateral or bilateral, affecting both sides.
Right. Is there a quick way to remember that?
Yeah, maybe think gyno growth and mastia breast. So growth of breast tissue, specifically hormone-driven growth.
Growth of breast tissue. Got it. Okay, so this hormonal imbalance sounds like it could stem from quite a few different things.
Oh, definitely. It's a broad area.
Yeah.
But yeah, the core issue is that hormonal seesaw tilting. This could be because the body's making more estrogen, or maybe it's making less androgen, or the breast tissue itself just becomes more sensitive to the estrogen that's around.
Right.
We usually split the causes into 2 big buckets. Physiological, meaning normal body stuff, and pathological, which suggests there's some underlying issue or disease process.
Okay, physiological first then. When is it just normal?
Well, normal might be pushing it, but it's certainly common and expected during puberty, with all those hormones fluctuating wildly. It usually settles down on its own in adolescence. We also see it more often in older men, often linked to naturally declining testosterone levels as they age.
Makes sense. Life stages, hormone changes. Okay, what about the pathological side? What kind of underlying problems trigger it?
So pathologically, a big one is a lack of testosterone. This could be from birth, like congenital absence of the testes, or conditions like Klinefelter syndrome.
Okay.
Then, on the other side of the coin, you've got increased estrogen levels. This might come from certain tumors that actually produce estrogen, or very commonly from liver disease. If the liver isn't working well, it can't break down estrogen properly, so levels rise.
Ah, the liver connection. Right.
And crucially for your revision, medications, loads of medications can cause it. Spironolactone, cimetidine, those are classic examples. But there are others too.
Right. You mentioned meds. That sounds like a really important category. Can you break that down a bit more? What types of drugs are we looking at?
Yeah, it's definitely high yield. We can sort of group them by how they mess with the hormones. So first you've got drugs that are estrogens or act like them, things like diethylstilbestrol, which isn't used much now, but also some herbal remedies can have estrogenic effects.
Interesting.
Then there are drugs that stop your body making testosterone, metronidazole, ketoconazole fall into this group. Others block testosterone from working, like cyperterone or flutamide, used in prostate cancer treatment sometimes.
Okay, stopping production or blocking action.
Exactly. And here's a slightly counterintuitive one. Sometimes even taking androgens, like anabolic steroids, can lead to high estrogen. The body converts the excess testosterone into estrogen via a process called aromatization.
Wow, okay. So taking male hormones can indirectly boost female ones.
Precisely. The body likes balance, or tries to find it. Other drug groups, well, some increase prolactin levels, and other things like certain antipsychotics, some antiretrovirals like efavirenz are implicated. And then a miscellaneous group, amiodarone, isoniazid, methyldopa. The list is quite long.
That's a lot to remember. Any tips for the drug causes?
Maybe think broadly about the mechanism, like some drugs increase estrogen, the estrogenic ones, others decrease testosterone, the synthesis inhibitors and blockers. Others affect other hormones like prolactin elevators. It's not perfect, but it might help scaffold the information.
Yeah, that helps frame it.
Hmm.
Are there other medical conditions, maybe not directly hormonal ones, that are linked?
Yes, a few others pop up. Long-term type 1 diabetes has an association.
Mm.
Chronic illness in general, possibly through inflammatory pathways affecting hormones. Spinal cord injury is another one mentioned.
Go ahead.
And sometimes, despite looking really hard, you just can't find a specific cause. That's when we label it idiopathic.
Frustrating, I bet. Okay, so we know what it is, what causes it. Who's actually most likely to get gynecomastia? What are the main risk factors we should keep in mind?
Well, the risk factors really echo the causes we've just gone through. Puberty is a big one, that hormonal roller coaster.
Right.
Aging, again, linked to shifting hormones, particularly lower testosterone.
Mm-hmm.
Medications, huge risk factor. We've covered that. Recreational drugs, specifically marijuana and anabolic steroids, are known triggers. Underlying medical conditions, especially liver or kidney disease, because they affect hormone metabolism and clearance. A family history can sometimes play a role. And obesity is another factor, partly because fat cells contain aromatase, that enzyme that converts androgens to estrogens.
Quite a mix then. How about a mnemonic for those risk factors? Anything catchy?
Let's try. How about PAMA-ARMO? P for puberty, A for aging, M for medications. Then another A for anabolic steroids and marijuana, R for renal and liver disease, M for medical history, including family history, and O for obesity.
PAMA RRM. Okay, I like it. Rolls off the tongue. PAMA RMO. Right, let's zoom in a bit more. What's actually happening in the breast tissue, the pathophysiology?
Okay, so at the tissue level, it's all about that estrogen-androgen imbalance we keep mentioning. Estrogen normally tells the glandular bits of the breast, the ducts and the supporting tissue, the stroma, to grow.
Right.
Androgens, like testosterone, normally put the brakes on that growth.
Mm-hmm.
So when the balance tips, more estrogen effect, less androgen effect, or increased sensitivity, that brake comes off.
Okay.
The ratio changes. You get proliferation, basically, more cells growing in the ducts and the stroma.
Okay.
Now, if this hormonal stimulation goes on for too long, the tissue can change. It can become fibrotic.
Fibrotic.
Meaning
so.
it gets sort of scarred and dense, thickened tissue. And once that fibrosis sets in, it's often irreversible without surgery, even if you fix the underlying hormone issue.
Ah, okay. So timing matters. Now, if someone presents with enlarged breasts, it's not automatically gynecomastia, right? What else should be on our radar? The differential diagnosis.
Absolutely crucial point. You always have to consider other possibilities. The big one, the most serious, is obviously breast cancer. Much rarer in men than women, but you cannot miss it.
Definitely.
Other things include lipomas, just benign fatty lumps, mastitis, which is inflammation or infection, and, as we mentioned before, pseudogynecomastia, just excess fat, no gland growth.
And differentiating from breast cancer is the absolute priority here, isn't it?
Without a doubt, that's number one. And making that distinction might need more than just an exam. It often involves imaging, like a mammogram or an ultrasound, and sometimes a biopsy is needed to be certain, taking a tissue sample.
Okay, let's talk numbers. How common actually is gynecomastia here in the UK? What's the epidemiology look like?
It's actually surprisingly common, way more common than most people think. If you look at newborns, because of maternal hormones crossing the placenta, the rates are really high, like 60 to 90%.
That's high.
Yeah, temporarily. Then during puberty, again, very common, maybe 50 to 60% of boys experience it to some degree. And then it peaks again in older men. In the 50 to 69 age group, estimates are around 70%.
70%.
Yep. So overall, it's thought maybe at least a third of all men will have it at some point in their lives. But, and this is the reassuring part, breast cancer is only found in about 1% of men presenting with breast enlargement.
1%. Okay. That's important context. So how does someone with gynecomastia typically present? What are the signs and symptoms we'd look for?
The main thing is that breast tissue enlargement, obviously, unilateral or bilateral. And when you feel it, it's often got a kind of firm, maybe slightly rubbery texture, which helps distinguish it from soft fat.
Okay.
Patients might also mention tenderness or sensitivity in the area. It's not usually acutely painful, but discomfort is common. And really importantly, even if it's physically mild, it can cause quite a bit of psychological distress, body image issues, embarrassment, that sort of thing, especially if it's quite noticeable or doesn't go away.
Yeah, I can imagine. So if a patient walks in with these symptoms, what's the approach? What questions do you ask? What do you look for on examination?
You start with a really thorough history. When did it start? How long has it been there? Is it tender? Any changes in sexual function, libido, erections? That could point to low testosterone.
Right.
Then a meticulous drug history is vital. Prescription meds, over-the-counter stuff, supplements, recreational drugs, marijuana, steroids, alcohol. You need to ask specifically, past medical history, family history of gynecomastia or breast cancer.
And the examination.
On examination, first job is trying to differentiate true gynecomastia, that firm, glandular tissue under the areola, from pseudogynecomastia, the fatty type. You assess the size, check for asymmetry, feel the consistency. Then you look for clues to underlying causes, signs of liver disease like jaundice or spironolactone, signs of kidney disease, signs suggestive of low testosterone like small testes. You check their overall sexual characteristics. Look for signs of other endocrine issues too, like thyroid problems or Cushing's.
Okay, comprehensive look. When do you go beyond that initial history and physical exam? What investigations might you order?
Often the clinical assessment is enough, especially if it's typical bilateral gynecomastia in puberty or in an older man with no worrying features. But you definitely investigate further if there are atypical features, like if it's strictly unilateral, very hard, rapidly growing, or painful. Or if you suspect an underlying cause that needs confirming, or if you just need to definitively rule out something else like cancer.
And what tests would that involve?
Blood tests are usually the first step. Things like kidney function, UNEs, liver function tests, LFTs, thyroid function tests, DFTs, and then specific hormone levels, estradiol, testosterone, maybe LH, FSH, prolactin. Beta-HTG and AFP are important tumor markers, especially if you're worried about a testicular source.
Okay.
In some cases, like if you suspect Klinefelters, you might do chromosomal analysis, karyotyping.
What about scans, imaging?
Yeah, imaging has its place. Breast ultrasound or mammography are often used if the finding is suspicious on exam or if it's unilateral to help differentiate from cancer. If the testes feel abnormal or those tumor markers, beta, HCG, AFP, are up, then a testicular ultrasound is needed. Occasionally, a chest x-ray if you suspect a lung lesion might be involved, perhaps producing hormones.
And biopsies.
The needle core biopsy is really the definitive test if there's any suspicion of malignancy. It gives you a tissue diagnosis. And if, after all that, you still haven't found a cause, then it's termed idiopathic gynecomastia, cause unknown.
Okay. Let's just circle back quickly to the male breast cancer link. You mentioned it's rare, but what are the key things to remember for revision, risk factors and red flags?
Absolutely. So male breast cancer, less than 1% of UK breast cancers, but important not to miss. Key risk factors include Klinefelter syndrome, having had estrogen treatment previously, a strong family history, especially with BRCA1 or BRCA2 mutations, and prior radiation exposure to the chest.
Right.
And the red flags, the signs that should make you think cancer rather than just gynecomastia, are things like strictly unilateral enlargement, a lump that feels hard or irregular, rapid growth, any nipple changes, discharge, retraction, or skin changes, dimpling, ulceration. If it's painful, gynecomastia usually isn't very painful. If the lump is large, say over 5 centimeters, and definitely if you feel swollen lymph nodes in the armpit, axillary lymphadenopathy.
Got it. And if those red flags are there,
then it needs urgent investigation, usually imaging and biopsy, and a referral to a specialist breast clinic is essential. No messing about.
Okay. So let's say we've diagnosed gynecomastia, we've looked for underlying causes. What do we do then? How is it managed?
The management really has to be personalized. It depends heavily on the cause, how bad the symptoms are, and crucially, how much it bothers the patient.
Makes sense.
If it's physiological, like in puberty, the main thing is often reassurance and watchful waiting. It frequently resolves on its own. If a medication is the culprit, step one is to see if you can stop it or switch to something else, obviously balancing the risks and benefits.
And if it persists or is really causing distress,
then you start thinking about active treatment. Options include medical therapy, primarily using drugs that block estrogen's effects, like tamoxifen, or surgical options like liposuction to remove fatty tissue, or direct excision to remove the glandular tissue itself. Sometimes a combination is used.
Are there specific UK guidelines on this?
Broadly, yes. The guidance usually suggests referral if there are red flags, as we said, or if the cause isn't clear and is causing significant distress. The choice of treatment should align with the patient's goals. Is it mainly pain release they want, or is it the cosmetic appearance?
Right.
Always treat the underlying cause. If you find one, stop the drug, manage liver disease, etc. If it's asymptomatic, not suspicious, reassurance might be all that's needed. Medically, tamoxifen is the one with the best evidence for reducing size and tenderness in some cases. Other drugs have weaker evidence.
And surgery.
Surgery is usually reserved for cases where no cause is found, or where there's significant fibrosis that won't respond to medical treatment. Or if medical therapy fails or isn't tolerated, it's quite effective cosmetically.
Wow.
Oh, and tamoxifen can also be used prophylactically to prevent gynecomastia in men starting certain hormone treatments for prostate cancer, for example.
Okay, that's helpful. What's the general outlook then, the prognosis?
Generally, the prognosis is very good. Physiological gynecomastia in puberty usually goes away by itself. If they treat the underlying cause or use medical therapy effectively, it can resolve. Surgical results are usually permanent and satisfactory.
Good to know.
So overall, it's mostly benign, and full resolution is definitely possible, especially if you catch it before that dense fibrosis develops. And it's a big, but we have to remember the psychological impact. It can be really distressing, impact self-esteem. So addressing those concerns is just as important as treating the physical aspect.
Absolutely. Are there any specific complications we need to be aware of?
The main complication, as we just touched on, is that psychological distress. Body image concerns, low self-esteem, anxiety is probably the most common issue. You can also have complications related to whatever the underlying cause was, or side effects from the treatments used for that cause. And if surgery is performed, there are the standard surgical risks. Scarring, maybe some breast asymmetry afterwards, changes in nipple sensation, bleeding, infection. The usual stuff.
But overall,
Overall, with a proper workup and tailored management, the risks are relatively low and the outcomes are generally very positive.
fantastic. Well, that feels like a really comprehensive run-through of gynecomastia, hitting all the key points from those revision notes.
Yeah, hopefully that helps consolidate things. We've covered the definition, the causes, physiological, pathological, drugs, the risk factors with PMA, RMO, what's happening at the tissue level, the differentials, how common it is, the clinical picture, investigations including red flags for cancer, management options, prognosis, and complications.
So definitely feel free to loop back to this deep dive whenever you need a refresher during your MSRA prep. Getting a solid grasp of gynecomastia really ties together concepts from endocrinology, pharmacology, and clinical assessment.
And don't forget those extra resources, passthemsra.com and freemsra.com are there to help you further.
Right. And maybe a final thought to leave you with. Thinking about gynecomastia, about how that hormonal balance can be tipped by so many different things. Age, illness, medications isn't just key for managing this specific condition. It's actually a great window into understanding just how interconnected and, well, sensitive our endocrine system really is. Thanks for joining us.